The UK has passed groundbreaking guidelines, opening the doors for free automated insulin delivery systems for a large portion of its type 1 diabetes community. Today, I'm going to uncover what healthcare looks like in a country with free universal healthcare and what access to doctors and diabetes technology looks like. Welcome to the show. I'm Justin. I have type 1 diabetes, and on here, I talk all things diabetes tech, news, and management with educators, tech leaders, and those thriving with diabetes. Joining me from across the pond is Anne-Marie Frohock. She is the lead pediatric diabetes dietitian at Oxford Children's Hospital and works for NHS England as a clinical lead for the Southeast region. There, she heads up access to technology for people living with type 1. Her and I get into what healthcare looks like in the UK, who is covered by these groundbreaking guidelines, and how they will be implemented. I also want this to be the beginning of a larger discussion. If you live in the US or elsewhere, how do you feel about your healthcare system compared to the UK? And if you live in the UK, what has been your experience with universal healthcare and accessibility of diabetes technology? I'd love to explore this more, and if you have ideas of how I can, let us know in the comments on YouTube. Keep in mind that anything you hear on this podcast or content on my social media and YouTube channel is not medical advice and is for educational purposes only. Always consult with a physician before making changes to your healthcare. Anne-Marie, welcome to the show. It's good to have you here.
Thank you. Thank you for having me. Nice to be here.
Of course. Yeah. So we met at ATTD, and you had mentioned the new NICE guidelines in the UK. And just from our short conversation, it pulled me in, and I had to hear about what's going on, because this sounds like it's a big moment in the UK for diabetes care. Before we hop into that, though, can kind of just introduce yourself to everyone. What do you do in this space?
Sure. So my background is I'm a dietitian, and I work with children with type 1 diabetes in Oxford, and that's my main clinical role. So I live and breathe type 1 diabetes in my day-to-day life and work alongside some really inspiring families, and have always strived to do the best for them, which led me into a role also working for NHS England. So NHS England is the organisation that I would say kind of funds the NHS and provides the strategic oversight for NHS developments in all sorts of healthcare across the England and the UK. But for them, I work as one of the clinical leads in the Southeast region of England, and I head up access to technology for those living with type 1 diabetes, mainly children, but I also have some influence over the adult space as well. Okay.
So let's first explain to everyone, what is NICE? It's an acronym, not a person that's nice.
No.
It's an organization.
No.
Or
no.
What is it?
It's NICE is an organisation. NICE is the Institute, or the National Institute for Clinical Excellence. And NICE are responsible for creating clinical guidelines, I'd say, for how we as clinicians deliver care for patients with all sorts of conditions. So it's not just around diabetes. And the idea is that they set the bar. They set the standard as to what is the best standard of care that should be delivered across our NHS, so our National Health Service, which, as you would all know, provides free of charge healthcare for anyone living in the UK.
Yeah, so that's pretty different than where I live. I live in the United States, and here we have health insurance, which then dictates kind of what we are afforded, how much things cost. Often this health insurance is tied to your employer, or you buy it on like the national market. So I'm curious to hear all the differences. And I know that everything's not perfect in the UK also. Yeah, you have free healthcare for everyone, but we're going to get into some of the reasons why people still may not have access, or as easy access as we do have in the US, which is changes the way last time we talked, it changed the way I thought about it. Anyway, so kind of give us a bit of an understanding about what these most recent guidelines from NICE, what they say or how they've changed the requirements.
Yeah, absolutely. So just before Christmas, NICE delivered us, as anyone working in diabetes care, the most wonderful Christmas present that we could have asked for, which was some guidelines recommending that all children and young people and adults who meet certain criteria, being that they are pregnant, planning pregnancy, or have a high HbA1c, should have access to hybrid closed-loop systems, free of charge, funded by the NHS. And so that meant that for all of the youngsters that I work with, that they would be getting access to life-changing systems. They really are. And I know that you would have had so many other people on this podcast just saying how much their lives have been changed by these systems. And as someone working with people with type 1 diabetes, I see what they can offer and the changes that they can bring about. So this was music to our ears. We had this NICE guidance. And not only did we get delivered NICE guidance, it was actually delivered with what's called a technology appraisal. And technology appraisals, when they come alongside NICE guidance, are almost like a legal requirement that have to be met. So technology appraisals come with kind of a time scale for implementation, because obviously we've got thousands of people living in the UK with type 1 diabetes who would meet the criteria for hybrid closed loop systems. But there's only a certain number of healthcare professionals to support people moving on to these systems and providing the education and the care around optimizing using them. And so to reflect that, the technology appraisal came with kind of a 5-year implementation plan, by which time teams should have given access to and provided to all those who meet the criteria and who want it, this technology. And so that was the first kind of jigsaw puzzle piece that we had to be able to be saying, you know what, we know this is the best care, and we want to be delivering it to all the patients that we work with. But then, as you said, it's not all sunshine and rainbows, because although this has been declared and that this will be happening, there's a lot more kind of other puzzle pieces that have to be put into place around the funding of these devices, where the money's coming from, negotiations over kind of how we're going to procure those devices, which devices are going to be able to kind of meet the financial envelope, because obviously the NHS is funded from taxpayers' money. There's only a finite pot of it, and it's got to cover a lot of people. And then there needs to be a lot more kind of strategic input into kind of the prioritization within the criteria. So who goes first? How do we, as a limited team of healthcare practitioners and clinicians, decide really who should or who can go first, and how we are going to provide the capacity within our workforce to do all the work that's needed?
Yeah, and as someone who's an outsider looking in, I thought people in the UK, they had NHS, they had free healthcare, they got the care they needed when they needed it. But that's not the case. There needed to be these guidelines to tell everyone who is allowed or able to get this technology. What were the guidelines prior to this? Who were getting the AID systems and the CGMs? How did that work? And we'll get into what the exact guidelines of this are in just a second. But what did things look like before?
So before, it's a little bit more hit and miss. And I think certainly I can speak from a pediatric children's background, because we do feel quite lucky that we've been able to provide funded access to these devices much more freely than some of our adult colleagues. So I will talk from a pediatric place. It's very different in adults, and access was obviously much more limited. But we were able, and prior to this, there had been some other changes through NICE that said that all people in the UK should be given access to continuous glucose monitoring devices. So that meant that actually we were then able to provide various devices in various ways. So we use some of the flash sensors more readily, I think, than perhaps you guys do over in the States. And they're available along with some of the other devices that came to market a bit later. Some of the more basic versions of them that are available on prescription. So actually, they can be provided. And prescriptions in the UK, we do pay for a token amount. However, if you've got a long-term condition, then you're exempt from prescription charges. So that basically means that those people living with type 1 diabetes can have sensing.
Yeah, CGMs are free for their entire life.
Yeah. The problem is that the CGMs that then generally interact with the hybrid closed loop systems are more high cost. And so those ones are not prescribable, but would be able to be funded for certain people who meet criteria. And so for us within Children's, that was much more readily available for us to be able to use the higher cost devices that offer the functionality that interact with pumps to form hybrid closed loop systems. And again, insulin pumps pretty much under the age of 12 years old, according to previous NICE guidance, could be funded for children under the age of 12. And then over the age of 12 and into adulthood, there was other criteria that needed to be met to be able to access those devices. So there was more criteria that we had to meet. Does that kind of make sense? You're looking
absolutely
very quickly at me.
No, it does. What exactly, can you lay out what are the guidelines? Who is considered eligible now for AID first, I guess? Or what's that order?
All children and young people under the age of 18. Over the age of 18, or I mean, it may be that some of these are under the age of 18 as well, are people who are pregnant or planning pregnancy. And those with HbA1c over 75, I think it is in adults. You might need to double check that.
I believe it was 7.5% A1C and below.
Yeah.
And by the way, for everyone listening, I put the NICE guidelines in the show notes. If you want to read them yourselves, you can also go to the implementation plan is also in there and talks about how it's a 5-year plan. Today's episode is sponsored by T1D Exchange. You can directly make an impact on diabetes healthcare, treatments, and technology by participating in the T1D Exchange registry. It starts with a simple survey about your life with T1D, and it only takes about 15 minutes. After that, you'll have a personal portal with ongoing T1D study and survey opportunities. Plus, some of these studies even offer compensation. Signing up with the link in the show notes helps support my channel, and it allows me to continue putting out free content. You can sign up at t1dexchange.org/diabetic or click that link in today's show notes. Interestingly, if you're 19 years old and your A1C is 7%, you are not you're not part of these guidelines. Are people raising their A1Cs? Would you, in your opinion, do you feel like people are incentivized to raise their A1C a bit, be a little bad for 3 months, just so they could be good for the rest of their lives?
I think that's more of a question for your community. I feel that it's really, I'm not dodging the question. It's a really tricky question for me to answer because I actually mainly work with young people under the age of 18.
Yeah.
So I feel like I'm perhaps not the best person to answer that.
Let's hear from the listeners then.
Yeah,
listeners,
really
if you
interested to hear what they say. But I also think that in the adult space, the message is very much that it's a 5-year plan. We will get to everybody. We will get to you, but we can't do everybody all at once.
And does the 5-year plan
to do that?
Yeah, and we'll get into. I want to hear more about that. Does the 5-year plan only cover this group of people you're talking about, or is this like the group of people at first? So so the first 5 years is just this category.
Yeah.
Okay.
So within the adult space, I think that at the moment, mainly teams are focusing. I believe, and from my experience of speaking to colleagues, that they will be focusing on those who are pregnant or planning pregnancy, because that's actually where we know that tight glycemic control is most impactful and most precious for a safe, healthy pregnancy, birth, neonatal period. So it makes sense. I think it makes sense to anyone that actually within a limited pot of resources, of staffing, for example, that the attention is focused on, I would say, probably the most precious group to start with, and then roll out.
How are they prioritizing people within that group of people? Is it kids first? Is it or is it just whoever comes to them first? And is there a wait list? Kind of, what is the process?
I think every team will be very different. We work in the UK, we tend to work very separately from within children's and adults. So children's teams will look after youngsters under the age of 18 with type 1 and type 2 diabetes. So we work quite autonomously within a children's service. And then from about the age of 16 and a half, 17, up until 18, we will begin to transition our young people over and hand them over to the adult services. So often adults and pediatrics do work very differently or very separately, but we have this bridging transition service in the middle to pass over and to hand out our young people onto adult care. So adult teams, I can't answer for them because I'm not necessarily working with them as much as to their approaches for prioritization. But within children's teams, every team is doing it slightly differently, depending on their capacity, their confidence as healthcare professionals with using the systems, and again, within what their local arrangements for paying for these devices is going to be. Because at the moment, the framework for kind of the financial side of it and the funding is still being worked through in nationally and then locally in many areas. Because the way that NHS money flows is that we have a pot of money from NHS England that then gets spread out into what we call integrated care boards, which spread out across the UK. And those integrated care boards then use that money to fund health services and provide equipment, provide drugs, high-cost devices such as insulin pumps. So there's a few steps of kind of planning, business planning, budgeting, and things that need to be put in place. And everyone's at different levels of development and progress with that. So at the moment, there is still little pockets of differences across the UK as things are being worked out. And that's where my colleagues in the NHS England teams, because we have clinical leads across the UK, are kind of working to kind of make sure that we're advocating for the children and families that we're working for with type 1 so that we can make sure that those processes are being made and being put in place.
Yeah, you mentioned you now have a role in all of this. Tell us a little bit more about that role, but also what inspired you to get involved? It's a lot of work, I'm sure. It's adding a lot more work to what you do. Yeah.
It is a lot of work, and it's very different to being a dietitian, teaching people how to carbohydrate count, manage exercise, and use their devices. So yes, it is very, very different. What took me into that? I think experiencing or living the experience of alongside the families that I work with, when we hear, okay, this patient that I look after who lives in this area can get access to a pump, for example. This is before the guidelines came out. But actually, my other patient that happens to live down the road and in a different county, who's funded from a different pot of money, well, the application process for them is very different. The criteria is very different, and they may not be able to get a device that this person can. And I was just very passionate about getting rid of that kind of what is often called in the media in the UK, what's called a postcode lottery. Or for you guys, it'd be like a zip code lottery. Like just because of where you live, it tended to kind of perhaps potentially affect the access that you had to some of these devices, even though we have a National Health Service that suggests that everyone should be getting the same. So I think it was partly the drive to try and smooth some of that out, get rid of some of that that disparity in what people can access. And to, like I said, to be an advocate and to try and get things moving in the technology space and in the diabetes space so that we can all have access to the same devices, the same level of education, and that all children, whatever background you come from, wherever you live in the UK, whatever of your own income that you have to perhaps be able to put into your diabetes care, it doesn't matter. You can all still have the same access, you can all wear the same kit. You can all have the same hybrid closed loop systems.
Yeah. You know, advocacy like this and you spending your time to help people and other people out there doing their part, it's so important because things like this wouldn't get done as quickly or efficiently or at all. So thank you for what you're doing, you know, for your part in all of this to help people get access, because the technology exists. Life can be easier and should be easier for all these people. So I'm glad. Yeah.
Yeah. And I think when it comes to the children and young people that we work with, it's not just their lives, it's parents, it's carers, it's school. The number of mums that come back and dads because we've slept. We've had the first night's sleep in 10 years.
That's amazing.
It's amazing, isn't it? And I think that even if it's just little things like that, yes.
It takes the burden off of even thinking past that, like the mental health toll, the toll on therapists, psychiatrists, psychologists that then have more time because the people with diabetes aren't as mentally strained and all of the, you know, the layering there. It's hard to truly understand the effect that you or I or anyone else helping people get on this is having, because it's not just one person, it's them and, you know, everyone who surrounds them. I kind of wonder if you're able to give us some insight on something like this that has happened in the past. So you said that everyone has access to CGM now, but I can only imagine there was a time, probably not that long ago, when access to CGMs wasn't a guaranteed thing, that the NICE guidelines, were there NICE guidelines that had come out? Was there a 5-year plan? What did that look like? And when was that?
Oh gosh, now you're asking me. I can't remember the dates.
Okay.
I feel like I've been in clinical day.
That's fine.
So we had, so the recommendations, so NICE changed their guidelines for diabetes for adults and children sometime before the technology appraisal and the hybrid closed loop guidelines came out, which stated that everyone should have access to CGM, regardless of age, that it should be provided. And it took time. It did take time. And I think what helped was, so you have a policy change. The policy changes, the guidelines change. But that change then doesn't get translated to a person being able to stick a sensor on their arm overnight, because there's so many steps in between that happens. And there was a lot, one of our clinical lead, Professor Partha Carr, is very active on social media. You would have heard of him. I'm sure many of your readers will have come across Partha, who was very open about naming and shaming areas of the UK that were or were not funding and providing CGM, and would publish maps and dashboards saying, yeah, they're doing it, no, they're not. And actually, just by comparing and having kind of it was almost like a leveling out, really. Like, if your neighbouring ICB is doing it, why aren't you doing it? And it worked. It meant that actually the people working in more kind of strategic business roles within the NHS were then putting in place local arrangements to be able to find the money to fund this, which then translated into it being on someone's arm. But that takes time. And I think that is kind of the role of clinical leads within the NHS, is to be part of that and to know who you need to talk to in the ICBs, in their commissioners, in the commissioning teams, in the management teams, in other transformation teams, to actually just keep going, keep pushing, keep pressing, saying, okay, they're doing it, why aren't you? They can do it this way, and helping them in create capacity, create funding, whatever they need to do.
What would you say is the current status of the adoption rate of CGM for people who need it? Because it is so accessible. Yeah. It's free and then pumps after that. Let's talk about AID currently, the adoption. Let's start with CGMs.
So CGMs, I don't know what uptake is generally. In my own local service, I'd say we're at 98% of the children and young people that we work with wearing some form of sensing. So few people choose not to wear it. They don't like visible things. And this is a piece of work, I think, that this is where I really enjoy speaking to people like yourself and other people within diabetes communities to understand some of these personal barriers to technology. I can understand access barriers. I can understand other kinds of reasons that actually that acceptance, that adoption isn't there because people aren't being given access to it. But actually, what are the reasons behind if I say to someone, here, have a hyperclosed loop system, we can put it on next week, and they say no. And those are the kind of the other reasons I think that we can have all the policies and all the access and all the funding in the world, but there are still going to be people that don't want to wear technology and be attached all the time. And I don't live with diabetes, so I can only hypothesize and try and understand those reasons.
Yeah, and what about people who don't have access to a pump right now? They're not going to have access to it. I assume they have the option to buy one. Are people going to do that?
Yeah, I don't know if they will. Historically, we've had some people that we work with who do self-fund their devices. And we've also worked with people who previously, before hybrid closed loop commercial systems were as available, would be doing DIY looping. Learned a lot from some of the families that I work with who have been previously doing DIY looping. And it's hard. It's a really hard situation to be in. And I'm sure that there may be people that you know who even if they could act, but they end up having to pay for it themselves. I guess it's kind of the same thing that you guys have to do with all the insurance payments and things, isn't it?
Yeah, I mean, I think at a basis, the nice thing about the NHS is that everyone who has type 1 diabetes is getting some form of treatment for free. They're getting their insulin, they're getting their CGM, and slowly they're getting more and more. And as more technology comes out, the guidelines will change and yada, yada, yada. In America, if you don't have health insurance, it is prohibitively expensive for insulin, for a CGM, for a pump, for all of it, to a point where people are struggling for just the insulin. Yeah. And it's a problem. I'd like to talk more about it on this channel. If anyone listening knows someone I can talk about or is the person to talk about, please comment or better yet, DM me on Instagram. I kind of want to get a clear idea of the implementation to this. You say it's a 5-year plan. So it sounds like in 5 years, they hope to get it to everyone who needs it in that bracket, potentially open it up. Do you have any thoughts on what the plan is now, or how is your office kind of navigating that plan in your own way?
So I think there is going to be some national recommendations for the implementation, and what would you say, kind of processes for kind of funding and all of that scaffolding really around it that we need to support it, which is one element. That's one pillar, I would say. And then we have the other pillar, which is the clinical implementation and how our teams going to be able to create capacity to provide the education, the care, the support around the user, around the patient, around the family who's going to be using these devices. And when you think about children and young people, that's also a lot of support and education in schools. So when kids with type 1 go to school in the UK, many of the teachers will very amazingly step up and deliver insulin, support with carb counting, and do all of that. So there's a lot of support for schools and education and care plans that need to be built into kind of like the rollout of hybrid closed loop. So teams that, again, we in pediatric teams have been using these devices a bit longer than our adult colleagues, so we've got a wealth of experience.
Interesting. Are you saying that a lot of prescribers or physicians with, adult physicians, because they haven't had a requirement or guideline to prescribe this technology, they're not necessarily all up to date on how it works and how it should be prescribed? Is that?
Yeah, not necessarily how it should be provided, but certainly, I mean, we know, and I'm sure you've covered on this, all the little kind of, there are so many differences between all the different algorithms. And I'm sure you've spoken about this an awful lot on your channels. And so knowing kind of like how to tweak all the different devices, which talks to which sensor, how you optimize them. So there's a lot of learning that as healthcare professionals we have done behind the scenes to then be able to sit with a user and say, right, you're about to do some exercise. You need to do this, you need to change this setting, and this is what you need to do afterwards. And that will vary between every device. And knowing kind of like, as a dietitian, for example, which systems, how accurate you need to be with carb counting for each of the different systems varies, how the systems adjust and control that insulin on your behalf varies. So there are like real like little differences between the systems that influence how best it can be used, and also kind of like helping to set expectations for what these systems can deliver to the person wearing it and what the systems expect as well, because they are these little clever little boxes of amazing things, but they're algorithms at the end of the day. They need a constant stream of regular data going in. You do something different, they might have a little hissy fit and not know what to do. So you need to know what to do in those scenarios, and that isn't in a user manual. So that's where healthcare professionals can help.
How wide is the scope of the technology available? Are there a lot of different CGMs and a lot of different pumps available? Do the guidelines list out, these are the 4 pumps allowed, or I would imagine, there would be new pumps. So what does that kind of look like, the options for?
We've got a number of devices available, which I think is fantastic because all of them offer something different and there's not ever a one size fits all. So I would never want to work within a restrictive list that only offers 1 or 2 devices, because I know that there's going to be some people that those 2 don't suit. You can have a look on the NHS England NICE website. I think the current list of devices that are available are on there. And it's not a set in stone list either. So as new devices come on board, we will be able to add to those and add to the portfolio that we offer, and offer them within our clinical judgment as well, which I think is really important.
Yeah, I'm looking at the list right now. It's on the link that I put in the show notes. Number 2, information about hybrid closed loop systems. Lower down, 2.6, it lists out the different algorithms and pumps and CGMs that currently work or are available, but it does mention that it's not an exhaustive list and that there are other systems and interoperable components. I know some new pumps have arrived in the UK recently, which is fantastic. More options, the better. More algorithms, the better.
Yeah, but more of a challenge for us as healthcare teams to understand them and be able to use them efficiently and effectively, I think, as well, because it would be such a difficult situation to end up in where people were perhaps choosing devices or using devices that perhaps might be working better if it was a slightly different option for them just because of their lifestyle. And I think that those are kind of just little features that when you work with a lot of people with type 1 who use a lot of different devices, that you start to notice kind of which ones are working in certain lives and things that perhaps aren't working quite so well in a similar life. Do you see what I mean? It's kind
of, no, definitely. Yeah. What is the lifespan of a pump
choice
in the UK? 4 years. Okay.
It's warranted. Yeah. So each
same thing.
Same as you. So a funding cycle, for example. So say NHS or the NHS say, yeah, you can have a pump, you can have a high closed loop. You're kind of like using that for 4 years, with everything being funded.
One thing I was kind of wondering about is people's accessibility to their doctor, whether it be an endocrinologist, a nutritionist, a diabetes educator. You know, here in the US, we have to pay a copay for every time we see these people. And if you don't have health insurance, you're guaranteed none of these. You have to pay out of pocket for all these people. What is the cadence? Is there a cadence that people are seeing these doctors? And can you kind of just explain that to us? I'm very curious to hear.
Yeah, certainly. So diabetes care in the UK, again, it's very different in children and adults. In children, all care is provided by what we call pediatric diabetes units or children's diabetes services that tend to be attached to a hospital and are run by a multidisciplinary team. So pediatric diabetes in the UK is kind of is funded, as it were, through what we call a best practice tariff. So for every patient that we have, we get a certain amount of money to run that service per year. But we have to prove that we're delivering set outcomes in order to receive that payment. So as from our team's point of view, that's making sure that we're offering and seeing children and young people every 3 months, so 4 times a year. When they're seen by a multidisciplinary team, they come see a doctor, they have a HbA1c, they have access to a structured education program. So that might be delivered by a nurse, a dietitian, or an educator, depending on how that team's set up. They also have access to psychology, and they have all of their healthcare checks done once a year, an annual review as well. There's a few other criteria as well that we have, such as like emergency out-of-hours care and things like that if needed, and being offered technology. And so that multidisciplinary team will, like I said, have nurses, dietitians, potentially an educator, support workers, consultants, doctors, all the full MDT. So children's diabetes is very kind of, it's quite closely monitored. And so that's how we run. In children's. In adults, it varies. So it may be that if you've got type 1 diabetes, you might be seen at an acute hospital by a diabetes team, particularly if you're using technology. That's historically, insulin pump clinics have been run in hospitals. However, many are still seen in community practice, so by general practitioners, and we'll see diabetes nurses within community teams as well. So it very much varies in adults. They may only get seen every 6 months as well. So there's different services. We also have, and particularly in Oxford, we have access to an exercise clinic for people with type 1 diabetes as well, that we're very lucky to be able to run, because myself and one of the adult consultants are kind of have a background in exercise, nutrition, physiology. So we run special exercise clinics that can see either children or adults who are doing quite high levels of training with type 1 diabetes. So there's little pockets of other specialist clinics that you can access as well. And again, that's all on the NHS, so you don't pay as you go.
Yeah, that's amazing. You don't pay as you go. Everyone's getting these services for free, which is...
And we chase, if people don't turn up, we chase them.
That's good to know, because I think that there's a lot of hearsay that people are having trouble getting appointments, and at least in this community, it's good to know that people are getting those appointments.
I mean,
getting
that's
chased
from
down.
a people background. I think. I mean, maybe very different in adults. Yeah.
Okay. If anyone has experience in the UK with that, let us know in the comments. So these guidelines are amazing. The future is bright. Do you think everyone who is could be a part of this will be part of this? Do you think everyone who can get the technology will go look to get it?
I hope so. And I would encourage them to do so, but do so with kind of like a bit of an understanding that there is only a certain number of people that can help you do this. There's only a certain number of doctors, nurses, dietitians to get you that pump, to do all the admin and all the education and the training and everything around it. But I would hope so. And I think it's been quite well publicised, I think, in the media in the UK that this is groundbreaking. We will be the first country in the world that gives access to hybrid closed loop technology through funded healthcare, which is unreal.
Do you think that there are any other ways that we could help people embrace the technology?
Yeah, I think, and this is something I think that the diabetes community is just so valuable for, is for those technology users who have had wonderful experience, who have got great life-changing experiences with this technology, can share those. And for perhaps those that are living with some hesitation about adopting technology, could reach out to those more experienced people to say, really, what is life like? How different is it? Just get some lived experience of it. I can't give that. I can't give that. I can do it through hearsay and say, I've seen this, I've seen that, I've worked with it. But I can't give that. And that's something that the community is so valuable for.
Yeah. Anne-Marie, thank you so much for all the insight you provided on this, on these guidelines and how it's going and what things kind of looked like. I think you definitely gave me a clearer understanding of what things look like in the UK, and it's fantastic that this is so groundbreaking. I didn't realize it was so groundbreaking. I wish everyone in all the other countries in the world had, who have universal healthcare also had easy access to AID. I guess that was something new that I learned today, and I hope that, more and more people can get on it.
Yeah. But I also know that it's a very privileged place to be in as well.
Yeah.
And I don't think anyone working in the field in the UK would say otherwise. I think we do realise it, that we are very lucky to be able to be offering this, and that there are so many places that are not on the same level.
Yeah, I feel the same, for sure.
Yeah.
Now it's time for you to share your story. Make sure to comment on YouTube with where you live and what your health insurance system is like and the accessibility to technology. I'd love to hear it. And if it makes sense, even go into kind of your tax rates and how that affects your healthcare. Thanks for listening. There are new episodes every Monday on podcast platforms and on YouTube in video. Links to all my social pages and YouTube channel are in the show notes. I'm Justin, and I'll see you next week.